Acute pancreatitis per the step-up approach. Typically, it's diagnosed with a CT scan, noting peripancreatic edema, fast stranding, and non-enhancement. When we look at pancreatitis, we have to assess the severity. And you have mild acute pancreatitis, and you'll have moderate to severe pancreatitis. The way that this is determined is by the Atlantic classification. Mild is no signs of organ failure per the Marshall criteria, okay? Which is defined as the P to F ratio being less than, or for mild is greater than 300. Your creatinine being less than 1.8, assuming that your baseline is less than 1.8. And then it's your systolic blood pressure being greater than 90, okay? And responsive to fluids and no pressors. Okay. If this is the case, if it's mild, you do supportive care, which is NPO. But in mild cases, you actually do early enteral feeding. They found a improved outcomes with early enteral feeding as opposed to a prolonged NPO. Again, no antibiotics in these people. And if it's due to gallstone pancreatitis, then you will go for your cholecystectomy with intraoperative cholangiogram in the same admission. Okay. Now, for cases of moderate to severe, the next question that you have to ask yourself, so here's a question mark, is it necrotizing or not? Okay, so next question here, we're going to have non-necrotizing. Okay, and then we'll have necrotizing. The non-necrotizing, again, will have the signs of acute pancreatitis. You follow supportive care for these, as mentioned before. And if they resolve, then you're going to do, if it's gallstone pancreatitis, you're going to do interval cholecystectomy with intraoperative cholangiogram at that time. Okay. However, and if it's necrotizing, you're still going to undergo the supportive care at first and manage the symptoms as they are likely to get worse. Remember with necrotizing the rules of 20, which is that 20% of patients with acute pancreatitis are going to end up getting necrotizing disease. So 20% of these will get necrotizing, okay? And 20% of these will become infected. And so there's a whole management scheme for the people with necrotizing disease. So if you have non-necrotizing and you have symptoms, positive symptoms, depending on how many weeks from the initial event you are. So if it's less than 4 weeks, you have acute peripancreatic fluid collection. Again, the treatment of these is supportive. Usually these will resolve on their own. Greater than 4 weeks, this is a pancreatic pseudocyst. If they have a fluid collection, pancreatic pseudocyst. And the management for these are cystgastrostomy. either internal or external drainage, but internal drainage is preferred as opposed to external drainage. If this fails and it becomes greater than 4 weeks, we go to cystgastrostomy. But let's say in this arm of things over here with the necrotizing, they start deteriorating. Okay. Again, they'll likely have fluid collections on their scans, and if it's less than 4 weeks, it's diagnosed as acute necrotic collection. Okay. If it's greater than 4 weeks, it's called walled-off necrosis. Okay. The management for these are, again, you're going to attempt to manage these supportively. However, really what these need is the step-up approach. So this is the step-up approach. These do need debriding. The necrotic material isn't going to go away on its own. And this is using a percutaneous drain. If they fail to improve, then you upsize that drain until you don't have any other drains big enough to upsize it. Then you would move on to what's called a video-assisted retroperitoneal debridement, which is done through a 5-centimeter incision in the left flank to access the retroperitoneum and perform dissection with laparoscopic instruments. And if this fails, then you have to go for open necrosectomy, which has a rather high mortality and morbidity. If there is gas on the CT scan, it means that they are infected. And this follows the same approach, but you add antibiotics. Okay. Other conditions you can have with acute pancreatitis, which would also be severe, is you can have cholangitis associated with it. In these patients, you will proceed with administering antibiotics. This is the other indication for antibiotics in the setting of acute pancreatitis, is with cholangitis or infection noted by gas on the imaging. So antibiotics plus emergent ERCP. You could also have hemorrhagic pancreatitis. This is noted by your, you see bruising, you have ecchymosis, you have the bilateral flank or the periumbilical signs that you can have indicating hemorrhagic pancreatitis. This is going to be treated with angioembolization. And if that fails, you have to go towards surgical hemostasis. Another complicating feature you can have is acute compartment syndrome, and this is going to necessitate a decompressive lap.